First thing I'm going to do is I'm going to wash my hands. I'm in the client's room, 20 to 30 seconds with warm water. Dry my hands. And shut the water off. Next, I'm going to introduce myself. My name is Mark. I'm going to be your student nurse today. I would put gloves on. And I would identify the patient. Once I identified the patient, I would do 3 things to prevent ventilator-acquired pneumonia, which is VAP. 3 non-pharmacological ways a nurse can help their client prevent VAP on their shift. Number 1 is elevating the head of the bed. We would elevate the head of the bed to 45 degrees. This would promote lung expansion and prevent aspiration. Once they're sitting up at a 45-degree angle, the next thing we would do to prevent VAP is mouth care. Mouth care should be done Q6 hours. So if a nurse is working a 12-hour shift, that nurse needs to find time to do mouth care twice on their shift. To do mouth care, you use chlorhexidine and you use a toothette. It's very important when you're doing mouth care to cover the client so they don't get wet. And it's also very important, after you cover the client, when you're doing mouth care, to take special note of where the mark is according to the edge of the lip on the client where it's documented. Because this is supposed to sit 4 to 5 centimeters above the carina, and you need to make sure that the client has equal chest expansion and that you're not disturbing the ET tube when you're performing mouth care. When you're performing mouth care, you use a toothette, you use chlorhexidine. This is very important because the ET tube is going right into the trachea, and it's a direct pathway for bacteria and pathogens to get right into the lungs and cause pneumonia. So what you do is, with the chlorhexidine on the toothette, making sure not to disturb the ET tube, noting the marking at the edge of the lip where it was documented in the client's chart, you perform mouth care. Be very careful. A lot of nurses who don't perform mouth care don't want to deal with this because you have to be very careful. This is their lifeline. So it's important not to disturb the lifeline, but it's also important to clean the mouth. The mouth is the dirtiest part of the body, and this client has a compromised airway, compromised lung. So performing mouth care is crucial to preventing pneumonia. The chlorhexidine cleans the mouth, and you clean the tongue, clean the gums, wipe it all around the teeth, just enough so that they don't have extra liquid choking in the back of their mouth, the throat. And then when you're done, you throw this away. A non-pharmacological way a nurse can prevent VAP, the third way, is spontaneous breathing trials, SBTs. So, after the mouth care is done, we would do the SBTs. SBTs are done by weaning the client off the ventilator each day. So the client's head of the bed is sitting at 45-degree angle, semi-Fowlers. The mouth care is performed every 6 hours. And now that the vent is on and the client is hooked up to the vent is the brain that's breathing for the client. But the longer the client is on the vent, the less of a chance the client has of getting off the vent. So SBTs are a protocol a nurse can follow to get the client off the vent each day and allow the lungs to be exercised and build up the lung capacity. So the AC's at 22, the tidal volume's at 450, the PEEP's at 10, and the oxygen, FiO2, is 100%. So it's very important, knowing that this client's on 100% O2, to watch the client's vital signs closely when they're weaning. So the first thing you would look for is heart rate and respiratory rate. If heart rate is elevated and respiratory rate is elevated, and minute volumes and pulse ox and tidal volumes are decreased, then you know that the client is not tolerating the SBT weaning trial, and they need to go right back on the vent settings to maintain hemodynamic stability. If the client is tolerating the wean, you follow the protocol, and the protocol will dictate exactly when to wean, how long to wean, and when to go back on the ventilator settings. The SBT weaning process has been found to be in 5 out of 8 hospitals nationwide. The other 3 out of 8 hospitals that don't have a SBT protocol, it's the nurse's responsibility as a manager of care to take it upon himself or herself to collaborate with the respiratory therapist and the physician and set up a time specifically each day on his or her nursing shift to wean the client with an SBT weaning trial. So the protocol enables the nurse to autonomously act on behalf of the client and raise the head of the bed, perform mouth care, and SBT trials. So when a nurse is very busy throughout the shift and they only have 10 minutes, they may be able to fit in this SBT protocol within that 10 minutes. If the nurse is very busy, 3 out of 8 hospitals that don't have the protocol for SBT, they might not have the time to hunt down the physician, the respiratory therapist. So it was found in the 3 out of the 8 hospitals on average that don't have the SBT protocol that those ventilator clients did not actually get the SBT trial. So now only 2 out of the 3, raising the head of the bed and performing mouth care, were performed. But the other third nursing measure that could have been performed with a protocol was not performed. And so now the client has a 33% higher chance of getting that. So these are the 3 ways that a nurse can take it upon themselves to help their client and decrease the risk of getting that.
Mrs. Jennings, good morning.
Hi.
Hi, I'm Beverly. I'm going to be your nurse in the OR today. How are you feeling?
Oh, not too good today.
Not too good.
No.
Are you having pain right now?
I am.
Oh. What's your pain level on a scale of 1 to 10?
It's bad. I get 8.
Okay,
Yeah.
yep. I'm going to take a peek.
Okay. What are you going to peek at?
I'm just going to take a peek at your knee. Did you use the chlorhexidine prep last night before that the doctor gave you?
That wash?
Yeah, the
For the
wash.
yeah,
For the
yeah.
surgery.
Mm-hmm.
Okay, good, great. And you have your hat on already? You're ready to go, it looks
Yeah.
like. The nurses took good care of you. Just going to check out your knee here. Okay. All right. Also want to let you know that because you have diabetes, sometimes it can cause some post-op complications, including infection. So we want to make sure that we take care of your diabetes post-op and that we're taking care of your knee at the same time, okay?
Sounds good.
Okay, so the doctor will come in and explain all that to you in a couple minutes, and then we'll get you back for surgery, okay?
All right.
Do you have any questions?
Yeah, I'm scared.
You're
I
scared.
have
You're
anxiety.
Yeah, I know. I know. It's a tough procedure to have to go through, but as I said, Dr. Stipp will come in and talk to you about any other questions you might have, okay?
Thanks, Nurse Beverly.
You're welcome. Nurse Bruno, are you on my team today?
Yeah, I am.
All right. We're going to be replacing the knee of Mrs. Jennings today. So
Okay.
I'm going to get ready to come in the OR. I'll let you finish setting up the sterile field over there, and I'll be in to join you.
Sounds good.
All right. Thanks. Okay, so to get ready to go into the OR, you want to make sure you have a cap. Evidence-based practice has shown that it doesn't matter what type of cap. There's many different styles. There's a skull cap. There's a bouffant cap. There's a whole hood mechanism that a lot of people like to wear for orthotic replacement or ortho replacements. But evidence-based practice has shown that it has not made a significant difference what kind of a hood you may want to wear. So I'm going to go with this today because this is what I have. Most hospitals have their own laundered scrubs. You should go along with your hospital's laundered scrub policy when working in the OR. Coming in from the outside with outside scrubs sometimes isn't a very good idea because then you're bringing bacteria from the home. Shoe covers in the OR are necessary, caps, and when we get in there, we're going to get pretty sterile. We're going into a sterile environment, so we want to make sure we wash our hands before walking in. We want to make sure our hair is tucked, and we want to make sure our shoes are covered. So I'm going to wash my hands. In the OR, we use an alcohol-based product to wash our hands, which is a little different than the rest of the hospital, only because we want to kill all the germs. So we're going to wash our hands here all the way up to the elbows for 30 seconds at least here. You can sing, you can hum. We're going to wash here all the way up to the elbows. I also want to use a nail brush. Make sure you get all the dirt out from under the nails. Okay. Evidence-based practice has also shown that wearing masks in the OR is necessary along with quality, clean air to not get any bacteria into your open incisions while you're doing surgery. It's also necessary not to have too many people in the OR, such as vendors and students, even though we are students and we love to have these opportunities. Having too many people talking in the OR can often spread germs, and it often moistens your mask while you're working, or brings it down, quite like what's happening now, and also leaves areas for bacteria to grow and exist. So my hands are clean, and Nurse Bruno is going to help me gown up here.
Miss Beverly, are you ready to get gowned?
I'm ready, Nurse Bruno.
All right.
Thank you, sir.
You're welcome. You gotta review that, huh?
No, we don't.
Okay.
Thank you, sir. In the OR, we have a blue sterile field. Everything in the OR that is blue should not be touched until you are sterile. And very, very, very important because all of these, if touched and bacteria gets on any of these, you can introduce bacteria to your patient while they're in surgery, so we don't want to do that. Surgeons use sterile gloves. Oftentimes we use 2 sets of gloves in the OR because then if one happens to rip, then you still have the other one underneath so you're not getting infected by a patient. And also just to reduce the risk of your bacteria also getting back to the patient. So a lot of times double glove policies are included in the OR policy as well. So we'll glove. Sterile glove, I'm going to do just 1 set of gloves today, just for demonstration purposes. Okay, so we have caps, gowns, masks, shoe covers, and we have our sterile gloves, and we're ready to perform surgery on Mrs. Jennings. Good morning, Mrs. Jennings. You awake?
Miss Beverly.
Oh, you're awake this morning. Hi.
Hi.
It's a little early, I know, it's 6:30, but we're switching shifts and I'm going to be your nurse this morning, okay?
Okay.
I was with you in the OR the other day. I got pulled to this unit. How are you feeling?
That's right. Oh, a little groggy.
A little groggy still, huh? I'm going to check your knee out. Are you having any pain?
I am. Well, I guess that's to be expected, huh?
Pain is expected. But I'll see if you have anything else ordered for pain, okay?
Okay.
I'm going to check your dressing out. Checking a post-op dressing, the doctor usually changes the first dressing, not the nurse. So this is a few days later, and the nurse should be checking the dressing. So I'm going to check out your dressing. We're going to see how your knee's progressing, okay? So just to do a dressing change, we're going to take the old dressing off. I'm going to assess. I'm going to assess to make sure that we have no redness, no swelling. It's not hot to the touch, and your staples look great too. So that's a good sign. So I'm just going to redress you while I'm here. Okay. some nice clean gloves on. Well approximated. Dr. Stipp did a great job.
Yeah,
Did he come in and see you last night?
he did.
Oh, great.
He was in and out.
Oh, he was, huh?
Yeah.
That's him. He flies in and he flies out. All right, so just over the staples, some clean gauze, and we'll tape around it. Clean, sterile gauze, a little bit of tape. Okay. And you'll be working with PT today, I heard.
Yes.
Okay, great. All right, so I'll work on seeing if you have any more pain medicine. You have any questions for me right now?
No, thank you, Nurse Beverly.
Okay. How are you doing with your diabetes? Was it okay yesterday?
They checked it. Yeah, they said.
And it's been okay?
Yeah.
Okay, great. As I said before your surgery, we're going to keep an eye on that.
Okay.
Just because that can be a risk factor for infection. And you are on the antibiotic that Dr. Stipp put you on, so we'll continue that today. Okay?
Great. Sounds great.
All
Thank you.
right.
Nurse.
Call me if you need anything, okay?
Okay, thank you.
All right.
Hi, how you doing, Beverly? Welcome.
Thanks.
My name's Nurse Colleen.
Hi, Colleen. Nice to meet you.
Nice to meet you as well. Today we have a patient, and the patient has a central line, and we're going to be doing a dressing change. But first things first, we have to wash our hands. Beverly, it's really important, especially with a person who has a central line, that prior to and after you come in contact with them, that you wash your hands. Okay. Because they are susceptible, highly susceptible to infection. We want to wash our hands for at least 30 seconds. Good way to remember to do that is to sing in your head, unless you have a fabulous voice. Sing twice, happy birthday, okay? And this patient had his dressing changed about 7 days ago. And that is the norm for if he has a clear dressing. And with a clear dressing, it would be changed every 7 days. If it was a gauze dressing, it would be changed every 2. I'll let you step in here, have you wash your hands as well. How long have you been a student for?
Oh, this is my last year.
It is. When are you
Yeah.
done?
Oh, in May.
This time. Wow.
Yeah.
Only have a little bit more time to
Oh,
go.
I'm looking forward to it.
Congratulations.
Thanks.
And when we go into the patient's room, we are going to put gloves on.
Okay.
Okay? Hi, how are you?
Hello.
My name is Colleen. I'm going to be your nurse today. And this is Beverly. She's a student nurse and she's going to be observing.
Hi,
Sir,
Beverly.
how are you?
Hi.
Before we get started, could you tell me your name and your date of birth, please?
Bruno St. Louis, February 25th, 1995.
Great, thank you. I want to ask you a couple questions. Are you feeling any pain and where your central catheter is or anywhere else?
No pain.
Okay. Have you experienced any fever or chills?
I have not.
No? Okay. And have you noticed any redness or swelling around where your catheter is?
Nope.
Okay, great. We're just going to check it out. Come on over here, Beverly, so you can see. There's no redness, no swelling. Okay. What we're going to do is we're in here to do a dressing change in your catheter, okay?
Did you just say a dressing change?
Yes.
They just changed it last week.
Correct, they did. But with a clear dressing, the CDC recommends that it is changed every 7 days to prevent infection.
Okay.
Okay? All right. Well, what I'm going to do first is I'm going to give you a mask, okay? And I'm going to put one on as well.
You're the nurse. Why do I need a mask?
Well, again, to cut down on infection. And when I do take the dressing off and when I am cleaning around the central line, you're going to have to turn your head to the opposite side. Just another precaution to avoid infection, okay? Spreading infection. Here you go. Put that on. Here you go, Beverly.
Thank you.
Great, thank you.
Is that gonna hurt?
Yeah, it's just going to tug a little bit, that's all. Okay. Success. Great. Okay, well, I'm going to go out of the room. I'm going to rewash my hands again, and I'm going to come in and I'm going to get some sterile things to clean and disinfect, okay?
Okay.
All right, great. Okay, so I've come back, I've washed my hands again, and to perform the cleaning of the catheter site, I need to use sterile technique, so I have sterile gloves on, I have a gown on, and the mask. Okay, so first what I'm going to do is I'm going to use the chlorhexidine, and I have to scrub vigorously in order to get rid of any infection or any germs.
Is that to clean it?
Yes.
Can you use alcohol?
Now, the CDC recommends that chlorhexidine works better to kill germs and prevent infection. Okay? I just need you to turn your head to the side. I'm just going to clean around the area, and it has to be vigorous rub. And I start from the middle and go out about 2 centimeters. And we're going to wait for this to dry before we apply a new bandage, about 30 seconds. How you doing there?
I'm doing fine.
Great. Any questions?
No questions.
Good. Okay. Okay. And then I'm going to use a second chlorhexidine, and I'm going to scrub the hub and reattach you, okay?
Okay.
Okay, and we're all finished, and we just have to document the date and the time. So the nurse, when they come in 7 days from now that you know,
Okay.
that they're going to have to come in and change it, okay?
Okay.
And everything feels okay?
Yep.
All right.
Thank you.
Any questions?
No.
Great, thank you.
Thank you. Hello.
Hi.
Hi, my name is Bruno. I'm going to be your ER nurse today. Can you tell me your name and date of birth?
My name is Bev, and my birthday is 9/1966.
Okay, thank you. What seems to be the problem today?
Oh, Nurse Bruno, I'm so uncomfortable. I haven't been able to urinate since this morning.
Okay. All right, give me 1 second, and I'm just going to look at your stomach.
Okay.
Okay, I'm just going to take a look. Is that okay?
Yes?
All right. All right. Going to take a listen right now.
Okay.
Okay. Okay, and now I'm going to feel on your abdomen. You let me know if you feel any pain, okay?
Okay.
All right. Does that hurt?
Ooh, that's very uncomfortable, Bruno.
Okay. Beverly is showing some signs of abdominal distension. This is one of the indicators of acute urinary retention. So what I'm going to do now is I'm going to obtain a bladder scanner.
Okay.
I'm going to scan your bladder to see how much urine you're retaining, okay?
Okay.
All right, I'll be back in a little bit.
Thank you.
Hi, Beverly.
Hi, Bruno.
So I just received the results of your bladder scanner, and it shows that you're retaining 800 milliliters of urine.
Is that a lot?
That's a lot. Normally, you're supposed to expel 30 milliliters in 1 hour.
Oh, wow.
So the solution to this problem is we're going to have to insert a Foley catheter inside of you.
Is that going to hurt?
You're going to feel some slight discomfort and pressure, but I believe after we get it in, you're going to feel better.
Okay. I trust you, Bruno.
Okay. A few reasons for Foley catheter insertion include acute urinary retention, bladder outlet obstruction, and selected perioperative surgical procedures. Some patients who are at risk include patients who are of advanced age, patients who are immunocompromised, such as patients with HIV or cancer, and patients who take immunosuppressant drugs, such as chemotherapy drugs and steroids. These patients are also at increased risk of developing a hospital-acquired infection if the nurse does not follow proper sterile technique or if the catheter is left in for an extended period of time. My associate Colleen here has helped me position the patient into semi-recumbent position. She also helped me prep the patient with soap and water. Studies have shown that catheter-associated urinary tract infections decrease if you perform peri-care prior to Foley catheter insertion. I have prepped my sterile field and now I am ready for Foley catheter insertion. I have already applied betadine to my cotton balls and lubricant onto my tray for the Foley catheter tip. I am now going to clean the area prior to Foley catheter insertion. I am now ready for insertion. Hi Beverly, how are you feeling?
I'm feeling much better now, Bruno. Thank you.
Okay. While the Foley catheter is inserted, there are proper guidelines for healthcare providers to follow. For example, the catheter should not be placed on the patient. The catheter should be placed at the level below the bladder. In addition, the valve should not be hanging. It should be inserted inside the Foley catheter bag. In addition to that, perineal care should be done twice a day and after each bowel movement. The sooner we remove the catheter, the less likelihood for Beverly to develop a hospital-acquired infection.